I see the participant numbers rising, so we'll just wait some more seconds, minutes. Okay, I think we can get started. For sure, there will be more participants joining in because with 300 registrations, this is quite an impressive number. So welcome everybody to this EANS webinar of the peripheral nerve surgery section. I am Christian, and I am only tonight. I must say I'm only a neuro and nerve surgeon, and we will have the best of the MR experts in the field of peripheral nerve with us, and I'm very happy and I'm very thankful for all of you joining in. We have Professor Amrani from Mayo. We have Maggie McCann from Barrow. We have Daniel Schwarz from Heidelberg of Germany, and we have Daniela Binagi from, well, in between Buenos Aires and Quakenbrück. So a small place in Germany, and we will cover all the relevant issues of peripheral nerve surgery and what we are interested in. So it's about compression, it's about tumors. We will hear about nerve trauma and regeneration, and we will hear about pain. And for everybody who wants to contribute to discussion, please use the Q&A and not the chat. We will, of course, check it all the time. So the questions will be answered and discussed after each talk. So, with this, I hand over to Professor Amrami. It's a huge honor and pleasure to have you with us. And we are very curious to learn from you. So please go ahead.
Thank you so much. And I want to make sure my screen is showing here. So I'm so honored to be included in this group. And I want to say, not just a neurosurgeon, you know, we only serve at your pleasure. So hopefully we can provide information that will help you care for your patients. So my topic is MRI of entrapment neuropathies. And I think this is one of the most difficult areas for a radiologist because what we say often has a result for a patient in terms of what happens to them. So I just want to say I have no relevant disclosures. So entrapment neuropathy, and again, I apologize if this seems too basic, but again, compression of a nerve by a known or an unknown cause. So that's pretty broad. And as I said, I think this is really difficult for radiologists because if you say entrapment, it almost always means a surgical release. So that has a big impact for the patients. So I know that other speakers are going to talk more about neurography, but the way that we approach this here at Mayo is really to use high resolution T1 and T2 weighted imaging with very robust fat suppression. There are many different ways to achieve that. We do all of our peripheral nerve imaging at 3 Tesla. We've recently incorporated the deep learning options, which has made a difference in terms of shortening our exams. If the question is an entrapment neuropathy, typically we don't use contrast. I know Downey's going to talk more about diffusion weighted imaging. We don't generally use this in our practice, but other people definitely find it very useful. And sometimes the biggest problem we have is trying to localize a problem and cover the area with adequate imaging. So I'm just going to talk a little bit about common upper extremity entrapment neuropathies. These are kind of the list here. Thoracic outlet syndrome is one that we see a lot of. Neurogenic thoracic outlet syndrome, much more common than the vascular thoracic outlet syndrome in our practice. It's common in athletes, also older women here. Symptoms are usually exacerbated by position. We don't necessarily do a lot of positional imaging in our scanners, but some people, again, do that. But the main thing here is that MRI typically shows this segmental enlargement and T2 hyperintensity of the lower trunk. And you really can see that if you're looking for it. So this is just an example, and this is an outside exam. It's a 1.5T STIR exam, not what we would typically do. But you can see here this enlargement of the brachial plexus, T2 hyperintense, same thing here on the right side. And that just corresponds to exactly what we see on the drawing. And again, this is really common to see that focal segmental enlargement in T2 hyperintensity. And in the right clinical setting, that's really all you need. Quadrilateral space syndrome is something we don't see very often. Again, we can see here that the axillary nerve is bright, a little bit enlarged, and then the teres minor muscle shows subacute denervation. These are typically going to be associated with trauma or sometimes osteophytes, but in this case, it was idiopathic. Another option that we sometimes see with lower trunk neuropathy is with clavicular fractures, and you can see sort of this soft tissue density here. Again, this is an older exam, and so you can see the stir imaging, and it's causing this direct impingement on the lower trunk of the brachial plexus. Suprascapular nerve entrapment, something very common for radiologists to see, and these are always associated with slap tears of the labrum, and you can see a little bit of the little tail here. This one happens to be extraneural, but they can be intraneural as well. And then on the sagittal image, you can see the denervation of the supraspinatus and infraspinatus muscles. So we know that this is affecting both the anterior and posterior branches. I want to just mention this because this is not something that we typically see in our practice, but Daryl Sneeg, who's at the Hospital for Special Surgery, has done a lot of work on this area, working with Scott Wolf at HSS. And they really believe that Parsonage Turner and other types of inflammatory, what we would think of as potentially inflammatory neuropathies, are actually entrapment neuropathies that are related to constrictions. And you can see on this very high resolution neurography that they see this little focal constriction, and then this little localized low signal within the nerve is something that they've identified as a bullseye sign. Now, our neurosurgeons haven't been able to reproduce this, but this is something that is definitely out there. And I would say that Daryl and Scott have a lot of good evidence, surgically and otherwise, to show that patients improve with this release. So just moving on to the radial nerve, so that we know that on the posterior interosseous nerve, there are lots of areas where it can become entrapped. I'm just showing this image to show that you can see all of the branches. So you can see the deep branch and the superficial branch of the posterior interosseous nerve. And then you can also see here the median and ulnar nerves. In this case, these are normal. There's a little, seems a little bit bright compared to muscle, but that's pretty normal. This is an example of a patient who's got a posterior interosseous neuropathy by EMG and does not have any kind of extrinsic lesion. And these are hard, but you can see here that this is the PIN here. It's a little bit enlarged. It's got some focal fusiform enlargement, which is never normal. Nerve should always get smaller, going from proximal to distal. So this is a little bit large. And then we've got this denervation of the supinator. So this is a good example of PIN entrapment without a discrete lesion. And this patient actually did completely resolve their symptoms with decompression. This is another example of the PIN that's displaced by a ganglion cyst that's coming from the radiocapitellar joint. Again, these can be intraneural or extraneural. In this case, it's extraneural. And here's an example of the PIN being displaced by a lipoma. And again, pretty typical symptoms. And there is a superficial radial that is not affected. I want to show this example of a 35-year-old anesthesiologist with lateral forearm pain, diagnosed as having radial tunnel syndrome. His only symptom is he's got discomfort along his lateral forearm, got absolutely no objective findings to go along with it, no weakness. EMG was negative, and they obtained the MRI for confirmation. And again, the report was that the radial nerve is enlarged and there's supinator denervation. And so let's go in, let's decompress that. Well, the problem is when you start looking at this more closely, there's a radial nerve, there's a median nerve, there's the ulnar nerve, they're all hyperintense. So this is probably more likely related to something inflammatory. This was not treated with surgery, and this resolved with conservative treatment. And I think this is the biggest challenge that we have as radiologists, again, is this presumption that the indication is entrapment or radial tunnel or something like that, and we're going to identify something without digging a little bit more deeply. And this is just an example showing the superficial radial can also be affected by something like a lipoma. Even though there's fat around the nerve here, it's a little bit hyperintense, and this patient has dysesthesias of the thumb that resolve with surgery. So the ulnar nerve, again, largest, longest, unprotected nerve in the body. It's very common to see T2 hyperintensity in this nerve whether or not there's something really going on. You have to be very careful how you call it. It's very, and ulnar neuritis is very common. It's usually transient. So it's really important to be careful how we call these. Ultrasound can be helpful, but a Tenella sign can actually be provoked in a normal patient with transducer pressure. So here's an example of ulnar neuritis that's secondary to an accessory muscle. The nerve is enlarged, it's hyperintense on T2. And again, we know that this is an actual reason for entrapment. Here it is on ultrasound, it's hypoechoic, so it's edematous. And then here we see the nerve is quite large, and there's that accessory muscle. And this resolved also with removal of the muscle. Here's an example just of a more ordinary kind of ulnar neuritis that's related to this ganglion cyst. And you can see that both the deep and superficial branches are affected by this. And again, this completely resolved with resection of the ganglion cyst. So this is the major pitfall, I think, that we see. So this is a patient, a young woman who had pain in an ulnar distribution, no weakness. This is her pre-op image, and you can see the ulnar nerve here is pretty bright. You can see these individual fascicles. Here it is in the forearm. There's no denervation at all. So the question is, what does this really mean? Well, she decided to go on and with an endoscopic decompression, and now you can see the nerve is bigger. It's more boggy looking. The individual fascicles are enlarged, and we're starting to see some denervation changes in the muscle. She still got pain, so she went on to a submuscular transposition, and now we have more denervation. Nerve is still bright. And then she finally went on to a revision with subcutaneous transposition with Tenoglide. And you can see this nerve is massive now. She's got way more denervation, developed a post-op infection. And again, you know, we have to be so careful how we call these and really to take some responsibility for not just saying it's bright, it must be entrapped. The median nerve can have compression along anywhere along its course. In the proximal forum, it's pretty common to see actually abnormality related to phlebotomy or PICC placement. And then in the distal forum, we can talk about the EANS and of course the carpal tunnel. So it's not really, in most cases, we really don't need the image, but this is after carpal tunnel release. You can see here the denervation, and you can see here that the median nerve is not surrounded by fat, it's entrapped in scar. So this actually is something that went on to neurolysis. This is another case of a patient that was done for a different reason. And you can see here's the median nerve. It's sort of going in this more volar direction. It's not hyperintense. So this is a normal appearance after a carpal tunnel release. The EANS is another area that's super difficult, I think, really challenging. It's a motor branch, so that's important. Arises from the median nerve in the proximal forum, and it runs distally through the two heads of the pronator quadratus. You're all familiar with this OK sign. And what that inability to do that, it really is muscular weakness. So this happens to be an EMG needle injury, so that's actually not relevant. But you can see here the EANS. This is just basically to show that you can see it at every point. And here it is actually more distally where the EANS is enlarged. We've got some denervation of the pronator quadratus. There's PQ latency here. But the FTP and the FBL are normal. So this is incomplete injury of the EANS. And so you don't need to have the full cohort of symptoms or findings. In this case, there's extensor involvement. This is the EANS is here, looks pretty big, doesn't enhance. And again, this has actually got extensor involvement too. So this is inflammatory. This is quinolone toxicity. So just again, going on here, I think maybe I have a slide there. So lower extremity entrapment neuropathies. I have yet to see a real case of piriformis syndrome that I'm really comfortable calling 100%, but this is probably the closest that we've ever gotten. And you can see here that the sciatic nerve here is enlarged, it's hyperintense, and the sciatic nerve here on the left is brighter and larger than it is on the right side. But the only way to really diagnose this is with doing a diagnostic injection to see if the patient improves with local anesthetic. This is a patient who actually had a Botox injection for piriformis syndrome, and you can see how atrophic the muscle is. He still had symptoms, he still had pain, so this is another really difficult diagnosis. This is just an example with an accessory piriformis muscle. Lateral femorocutaneous nerve, pretty common to see entrapment kind of at the level of the fibrous tunnel after it divides near the ASIS. And you can see here, both the anterior and posterior divisions are enlarged and hyperintense. So this is what you want to see in order to tell this patient this is really entrapped. And again, this improves with the release. Just another example. This is, again, a different kind of entrapment neuropathy, and I would say we're seeing this more and more. This is the sciatic nerve. It's very bright. It stands out. There's denervation change in the gluteus muscles, and you can see there's a screw actually going right through that. This was an outside case that was referred to us, and the outside orthopedic surgeons just refused to do any cross-sectional imaging on this at all. And so the patient woke up with pain and weakness, and the screw was removed, and there was neurolysis, and this actually got better. Just another example. So this is a patient who had an MI in December of last year, had a heart cath, and then he had this Impella pump placed for 48 hours, which is this unique kind of heart pump. He developed large hematomas that were treated with external compression, and then he eventually developed numbness in his thigh. And so he came to us, and now we have this bright femoral nerve. Usually the femoral nerve is so small, it's hard to see. You can see here, it's not really enhancing, but there's enhancing soft tissue around it. And then you can see here the denervation changes. So this femoral nerve was injured, but also was surrounded by scar, and the patient improved, again, with neurolysis. And there was some evidence that this was actually getting better. With a fibular fracture, pretty common to see injuries to the peroneal nerve. In this case, the articular branch was affected, but the sparing of the tibia tells you it was really those extensor muscles that were affected. Soleal sling entrapment is something that we see pretty commonly, usually does not really have any real space occupying problem, but it's a common source of tibial neuropathy in our practice. And this is kind of an unusual one. So there's this massive big osteochondroma here, and the tibial nerve here is hyperintense. It's not immediately adjacent to that, but the whole area is crowded. So this actually effectively is an entrapment neuropathy. This is an example of tarsal tunnel syndrome. You can see here the lateral plantar nerve and the denervation changes with sparing here more medially. And then this is an example of a collegiate golfer who's got medial foot pain and new weakness. And you can see here this subacute denervation in the abductor hallucis muscle. And this is a really great example of jogger's foot. And this is a medial plantar neuropathy. There's the medial plantar nerve. After contrast, it really just got this very superficial enhancement. This is a really great example of jogger's foot. And here again, we just showed that neurovascular bundle and why that would become entrapped. And here it is here, right on T1, T2, pretty iso-intense muscle on T1. And then here is the lateral plantar branch, and it's massively enlarged here. It really is too big, too bright. And in this case, we see now the denervation changes in the abductor digiti minimi, and there's some fatty atrophy, and this is an example of Baxter's neuropathy. So this is entrapment of the lateral plantar nerve. So just a final thought, entrapment neuropathies are pretty common. Again, we don't see them often in our practice, but they're common. MRI is absolutely the optimal imaging modality, but you have to be so careful. You don't want to call an entrapment neuropathy unless you're really confident and really sure. So thank you for that, and I hope I didn't go too far over.
Thank you very much. Fantastic. I'm completely, blown away. It's incredible work because, well, this is something that I got to learn over time. To come up with these kinds of images, to see these small nerves, needs a lot of intellectual work behind it, because you need to when you show it like this, everybody thinks, okay, let's just put the coil and have the nerve visible. But this is not the case. So what is your main, when projecting the imaging, how do you approach this?
In terms of how we acquire the images?
Yes.
I think we really have a focus on high resolution imaging, just the same as I know Donnie did in her practice, is like we absolutely tailor the exam for individual patients and the individual indication. I think sometimes the challenge is, the EMG doesn't always localize it so well, and we might have to cover more area. But it's really a combination of the smallest possible field of view, highest resolution we can get in plane, and then the use of 3 Tesla helps us in terms of getting the appropriate signal to noise. including deep learning is making a huge difference because we're actually getting really beautiful images in much shorter times, because in the past, in order to get those high resolution images, we had to image quite a bit longer with usually 2 excitations. And now, again, because of the incorporation of deep learning, we're able to do it with a single excitation. But a lot of it is just making sure you have very good fat suppression so that you can really distinguish the nerve from the background, and then the high resolution T1 to see the relationship to the other structures.
Fantastic. So we don't have any questions or comments from the audience so far. So anybody of the panelists want to add something to the discussion? Daniel, please.
I would like to ask Kim, did you have cases of torsions?
I'm sorry, I can't hear you. Of
nerve torsion?
Oh, that is part of what Daryl and Scott Wolf are talking about, right? That there is sort of this torsion. And I've talked to Dr. Spinner quite a bit about this, and that's just not their experience at surgery. So it might just be, again, our referral pattern here at Mayo is quite different because we have a big peripheral neurology practice, a lot of emphasis on inflammatory neuropathy. But that definitely is something that Daryl and Scott talk about quite a bit, and they observe that, and they have, pictures in their papers showing it, but that hasn't been our experience or the experience of Dr. Spinner.
Just a very short comment. We have some cases exactly with this correlation to even find it intraoral.
Mm-hmm. But in MRI, it's not that easy to see. And we had 2 cases, and well, they're difficult. I must admit, they're very difficult.
Daniel, please, you wanted to.
Yeah, I wanted to comment. So thanks a lot for this excellent talk. Especially with regard to the contrast. You were mentioning that you don't feel it is hugely necessary. Do you have any indication for when it might be useful in your practice?
I mean, I will admit that we use probably a lot more contrast than most practices do. I would say whenever we have a peripheral nerve question, especially if it's coming from one of our peripheral neurologists, we tend to use contrast. When we have what we would consider by history to be a more straightforward question of an entrapment neuropathy, and we're really looking for morphologic changes and signal changes, that's really the instance where we don't. But I would say in our practice, it's the minority of cases, because there are some things for which contrast is very differentiating for us. So CIDP, we have a very specific contrast pattern, perineurioma, and some of the diabetic neuropathy, we see a lot of that, inflammatory neuropathy. And in those cases, we find that it's helpful. But again, if we're having a question of an entrapment neuropathy referred from a sports medicine person or something like that, that would be the instance where we'd be less likely to use it. But we always sort of err on the side of giving contrast, I would say.
Okay. I need to ask ultrasound questions since I'm a big fan of ultrasound. Well, just to make it very clear, I don't see it, I always perceived it as complementary. I don't think one is better than the other, or all these discussions, I think they are completely useless. I think there are indications, of course, where MRN is the best, location depending, and I think maybe also in the assessment of tumors. But something that is of course, always important for us, also in the compression neuropathies, if I think of TOS, that we have some kind of dynamic imaging. So in my opinion, and this is only my opinion, the possibility to have the patient moving, putting the limb into the provocative posture and so on, is we have a slight advantage of the ultrasound, and something that, well, goes back to one of the ideas of one of the big European nerve godfather, so to speak, Milesi from Vienna. He always loved and talked about the gliding tissue. Mm-hmm. So this is something we can perfectly access with ultrasound. How is your experience on that with MR?
It's very challenging to, do positional imaging in the MR scanner. We sometimes do it, but I would have to agree with you 100% that ultrasound is much better for that. And, we were talking about Peter Amadio here at Mayo, is one of the hand surgeons, and he's using a lot of ultrasound to look at the median nerve in the carpal tunnel and see the, how it glides, exactly what you're talking about. So I think I agree with you. I think ultrasound is really complementary, and especially if you're looking to localize something, localize a pain point, and it's very useful for doing diagnostic injections. And so I would agree with you. It's very helpful to have it in real time. If you have like a subluxing ulnar nerve, you can provoke that. I mean, all of those things are so much better with ultrasound than what we can do with MRI that's more static.
Okay. Any other comments? Well, one nerve that is, everybody, well, the patients are very difficult to treat and to handle, and the nerve itself, at least in imaging terms, it's the pudendal nerve. And so far, I don't know any of the radiological, both MR and ultrasound persons who say, okay, I know how to depict it and I know to tell if the pudendal nerve is affected or not. What's your opinion on that?
I have to agree with you. I think it's challenging, very challenging. We're limited by resolution, we're limited by how things blend into the background. So I would have to agree with you. And again, that might be an instance where ultrasound's super helpful.
Daniel, you want to comment on this with your
Yeah, I mean,
experience?
pudendal nerve is really difficult, and especially in terms of the patients that present with this kind of neuralgia. Yeah, I think unfortunately, we are still not there yet. Yeah, I mean, sometimes we are successful, but actually, it's just too often that it's not working well enough.
Yeah.
Well, what I use is more anatomical images. So what I try to see are more or less indirect findings. And I only can see the nerve if it is infiltrated by the tumor. Otherwise, to me, it's very difficult to say that I see the nerve with increased signal intensity or such a thing. It's very, very difficult.
Okay, so far the audience is just blown away and impressed. No questions so far. So I think we will move on from compression to tumors and to add another technique that we will later come back with, with all the speakers basically. And so the next will be Daniela to talk about DTI, DTT in tumors. So please go ahead, Daniela.
Okay, so the idea is to show you peripheral nerve tumors, but from a different perspective. And I will use and show you our perspective. So I have nothing to disclose. Let's see, next. Okay, which are the learning objectives? I will show you how a normal peripheral nerve looks like. I will use MR neurography, and I will show you some cases, tumoral cases, and I will try to show you the radiological findings and the visual clues that help us get a diagnosis. So as Kim has said, MR neurography is a tailor-made suit, and is tailored to the patient and the pathology. We need for these trained professionals, high field of view, field MR system. I use 1.5 Tesla, and we also need dedicated radiofrequency coils. And the basic protocol will depend, as I said, on the area that we will examine and the pathology. In this case, it's a tumor. So we will use T1, T2, and density that are our anatomical sequences, and T2 with fat suppression to depict where are the signal changes. And when we suspect a tumor, we will always use gadolinium because there are many pathologies that look the same or quite the same without contrast media. And then when we inject gadolinium, they have different enhancement. So the pattern of enhancement is very important. So how does peripheral nerve look like? This is a posterior tibial nerve at the ankle. We will see a round structure with fascicular pattern that is isointense to muscle in T1 and might have an increased signal intensity in some fascicles in fat suppression. This is the normal nerve. And if we inject contrast media, the nerve will not enhance, a normal nerve. Then which are the MR findings that I will look for? Well, first, we need to see if this enlargement of the nerve is diffuse or if it is focal, if it is solitary or is multiple. And this is very important because later on, I will show you these tumoral or pseudo-tumoral cases in which we are seeing an inflammatory condition and not a nerve affected by a tumor. So this is very important. We also will analyze the fascicular pattern and the signal intensity. And as I said, the enhancement pattern is very important. We need to remind ourselves to look at the fat planes surrounding the nerve because this will be very helpful to do some diagnosis. And we also have the diffusion tensor tractography to analyze. And in this case, we will see the tracts with different colors, and these colors are by convention. We will see the tracts that go from head to feet or feet to head as blue. The ones that go anteroposteriorly will be green, and the ones that go to the lateral sides will be red. Okay, so it is important to know that for us, for radiologists, a peripheral nerve enlargement is a distinctive radiological feature and have multiple differential diagnoses. So what I say to my residents, all enlargements of the nerve is not a neurofibroma or a schwannoma. So we have here all different cases. They all have different clinical history. And here we can see a femoral nerve in the pelvis. Here is also a femoral nerve at the proximal thigh. Here is a sciatic nerve at the sciatic notch. Here also sciatic nerves in proximal thigh. And here an ulnar nerve at the elbow. They all have different pathologies. They all present as enlargements. And we will see some cases. In this case, we have a femoral nerve in the pelvis. We have the enlargement. We can see the fascicular pattern, and we can see pre and post contrast media injection, and we see that some fascicles uptake contrast media. This was CIDP, which was not my first diagnosis, but the histology is the histology. So later on, I would like to know what Kim thinks about these images, because I've never seen a CIDP uptaking like in this nerve. In this other case, we have the enlargement of the sciatic nerve. We have some fibrotic tissue. In the sagittal view, we see also the enlargements with this dark signal and all this fibrotic tissue, and is easy to diagnose an endometriosis when we see a T1 with fat suppression, in which we will see this hyperintensity within the nerve that comparing to the post-treatment, we can see the changing. This is endometrial tissue that has been bleeding, and the darker signal is due to the hemosiderin deposits. We will go now to another case. This is the sciatic nerve at the proximal thigh. It is enlarged. but we went more proximal, and we saw all these tumoral mass solids that is a little bit heterogeneous, and we could see that the nerve was within the tumor, and the patient had a CT done before, which was diagnosed as normal. I asked for the images again, and as you can see, there were all these calcium deposits, and it was the histology was an heterotopic calcification. So there are some pathologies that might not come right away, but you need to think and at least have it as a differential diagnosis. And in this other case, this is a Hansen disease, ulnar nerve at the ulnar tunnel elbow level, and we have the enlargement of the nerve. That we can see that the fascicles are enlarged, and the external epineurum and perineurum have darker signal. This is quite typical. And finally, schwannomas and neurofibromas, and I can say that they share common MRI findings. Sometimes I cannot say which one is which, so I use, in this case, the DTT reconstructions to see the displacements of the normal fascicles, which is also important at the moment that the patient will go under surgery, because it's important to say where are the normal fascicles. And in the case of the neurofibroma, we will see the infiltration in the DTI-DTT. So the question is the DTT the key? And I want to show you two cases. In this case, we have this enlargement that is in the periphery of the nerve. We have these fascicles that are displaced. This is the axial view in proton density with SPIR or FAT-SAT. And we could see the DTT with displacement of the nerve. This patient was asked to be done without contrast injection. I said, okay, we will not send the patient back for another prescription. Everything seems to be schwannoma, but the reality was intraneural myopericytoma. So DTT was not the key in this case. In this other case, we see an enlargement of the sciatic nerve, isotensin T1, not very relevant in SPIR. We could see the tractography with some infiltration. Someone might think, well, this is a neurofibroma and the diagnosis is done. But the reality is that the histology was a perineurioma. So in these two cases, the key would have been the gadolinium injection. So the enhancement pattern is paramount. This needs to be part of the protocol. And jumping to the malignant side, and malignancy must be suspected. We have some signs. We have here a coronal view of brachial plexus with the axial view. And can we say that the margins are ill-defined or invasive? No, we don't have peritumoral edema. The diameter is bigger than 5 centimeters. It is heterogeneous. In this patient, DTI-DTT was not done. But one thing that I always look for is the angiogenesis signs. I try to look for these small lines that are in the periphery of the tumor and sometimes inside. And those are very small arterial vessels. And when we inject contrast media, we can see that there are also necrotic signs. So the angiogenesis signs are very important. But again, malignancy must be suspected. So take-home tips. Why should we include MRN in the diagnostic workup of a peripheral nerve tumor? First, because expands differential diagnostic possibilities. It can be something inflammatory, it can be a real peripheral nerve tumor. Also determines the localization and extension of the lesion, facilitating this way a safe and complete resections. And if we're not able to give a diagnostic or a differential diagnostic, we can tell where the fascicular biopsy can be taken. And the most important is that there is always a clinical history behind every image. So we need to know the complete clinical picture to be able to do a diagnosis. And a multidisciplinary approach is highly recommended. So thank you very much for your time. And I'm looking forward to the discussion.
Thank you very much, Daniela. Fantastic images and a lot of things to think about. So, well, the workup of tumors, as we can see, or what we call tumors, or what it encompasses tumors, is huge. And I think, well, at least in our practice, the cases of, let's say, not surgical or not primarily surgical relevant conditions become more and more because of the excellent imaging. So we see things that we did not see before. And I think the main intellectual work is to somehow categorize it and to know what to do with it. So I think this meticulous workup and to have a structured workup is the most important thing to do. So how is this handled in the other institutions? Professor Mami or Dan, you want to?
Well, I mean, I think that, first of all, what Donnie presented was beautiful. And we're always trying to do everything we can do to characterize these lesions. Again, I always like to tell our residents that surgeons don't like surprises. And so we always try to, just characterize things as much as we can with the tools that we have. And I think what Donnie showed is beautiful, the relationship of the nerve to the lesion, whether it's actually a tumor or whether it's something, again, inflammatory, hypertrophic, all of those things are, information that we're trying to provide to you as a surgeon so that, when you make the decision to go in surgically, you know what to expect. And we'll do our best to try to help visualize that for you with the images and then, also with the reporting. But that was a beautiful talk, Donnie.
Thank you.
What do you do with all the surgeons that request, let's say, not very specific imaging? They say lesion ? And that's it.
Well, I mean, we look at the notes, we work closely with our surgeons here. The biggest challenge we have are things that not necessarily coming from neurologists and neurosurgeons, but things that are referred to us from primary care or so on, where we don't get as much information. But generally speaking, we're pretty tightly linked with our surgeons. And if we have a question, we call them and they're very responsive. But we're very fortunate to have that relationship here. But otherwise we end up digging in the chart and going through and getting whatever information we can. Sometimes, I know this will shock everyone here, but we actually talk to patients and see, try to get information from them. And, we use everything we have, every bit of information we have.
Yeah, thank you very much for this excellent talk. So, I mean, yeah, tractography, has been around for quite some time. But still, I must admit, yeah, I think it's not always so easy to implement in the clinical practice. Is your experience actually that it provides much more details for preoperative planning than, let's say, high resolution three-dimensional T2 weighted imaging? Because what we rather tend to do, even for peripheral nerve lesions, is that we use high resolution 3D T2 weighted images such as TrueFISP?
I don't use 3D T2. I go for more anatomical views, and I work in a different way. I see all the patients, I talk with them, I do the examination myself. So for every patient, I try to adapt the sequence without losing what the MR neurography was made for. So I do all the angulations, and for example, to me, it's a catastrophe if the patient comes for a pelvic MRI saying that they want to see femoral and sciatic nerve because they have completely different angulations. So that drives me crazy. So in that case, I will do an examination to see the femoral nerve and another examination to do the sciatic nerve. The examinations are absolutely tailor-made. And I don't use DTI, DTT all the time, only as a secondary tool. To me, the most important are the anatomical views and how the tumor, in this case, the tumor, behaves with the contrast media. If it enhances, if it doesn't, how it does, and so on. I wanted to ask Kim, have you ever seen a CIDP with this amount of uptake? And we don't hear you, Kim.
Sorry, there, hopefully. Yeah, we actually do sometimes see it. I wouldn't say it's typical. We looked at a series of them, and a small percentage of them do show a greater degree of enhancement. I would say it always makes us a little bit less sure, when we see that very characteristic superficial fine enhancement, when you see it very high resolution, that's very characteristic. I'll get a little bit worried about something else, like something infiltrative, like amyloid or sarcoid or even a tumor. But we do definitely see it. And I would say often it's in cases that are a little bit more chronic.
Okay.
But unusual, for sure.
Yeah, very unusual. That was the first time I saw it in this equation.
I'm sorry. I'm sorry. Okay.
Yeah, just one question about this specific case. Do you know if in this case there might have been a situation like an acute activation just from the clinical file?
Well, the patient came to rule out perineurioma because it was a young lady. She was at that time 12 years old, and she only had motor problems and very specific. So CIDP was not in my diagnosis at all. But well, this is what the histology said.
But this will open another very nice discussion, because I know that there are groups, and they are present here, that because of the pattern of contrast enhancement, they say it's perineuroma and basta, and they will not even biopsy it. So this case puts some doubt on that, I would say, or not?
Yeah, I think Kim has the biggest experience in this topic. So I would like to hear what she has to say about it.
I think perineurioma has such a characteristic enhancement pattern. I mean, very rare for it not to have that, very, very rare. And then also, you typically see the chronic denervation changes. So I would say we're very confident when we make the diagnosis of perineurioma that it does not require biopsy. And since there's rarely any real surgical intervention for that, usually those patients just get followed up. Yeah. And I would say, and we can really make that distinction. Now, you can see CIDP in children. 100% you can see that in children. So you do have to be careful. But perineurioma in general is so characteristic that it really does not require biopsy in most cases.
Okay. There's a very interesting question from our good friend Carlos Rodriguez from Mexico. He asks, so first of all, wonderful talk. What about distinction between a brachial plexitis post-radiation versus a brachial plexus tumor recurrency with MR? Is it possible with MR, or you recommend in addition a PET? This is a very challenging and interesting question, I think, for everybody involved. So who wants to start? Daniel, you want to?
Brachial plexitis and tumor recurrence is sometimes it's difficult, but I would say that the contrast enhancement in plexitis with fibrotic tissue most of the time is homogeneous. So, and then I use diffusion to have more data. And there's also, I need to know, for example, when was the patient irradiated, how much irradiation she or he received, and when the symptoms started, because these are dynamic processes, and sometimes we see, depending on in which phase we see or analyze the images, they will change over time. So if I see homogeneous enhancements, I would say that I do not get nervous. But if I see heterogeneous enhancement and some necrotic tissue, or then I'm not, I would say that is most likely a recurrence. I don't know what Kim has to say about it.
I mean, we find that a really big distinction is we're looking a lot at radiation fibrosis versus perineural spread of tumor, especially for patients with breast cancer, for example. And the pain is a huge distinction. And so if people have pain, we generally don't call that radiation fibrosis, no matter what it looks like. But I also agree that it's got a pretty characteristic distribution related, depending on the time since the radiation. There's secondary signs like lung fibrosis, all of those things kind of support it. But I would say the clinical presentation and the EMG, myochymia, obviously really important in this instance. But anybody with pain, we would be very hesitant to call that radiation fibrosis.
Daniel, what's your opinion on that?
Yes, it's a very good question, and actually, it's a question I don't want to say we get all the time, but we have seen quite a few of these cases, and I must admit, in most cases, if in doubt, it rather tends to be a recurrency actually, because at least it depends maybe also a bit how long the radiation dates back. Because maybe sometimes if you have long-term survivors with irradiation being done maybe in the 1980s or 1990s, it might still be that they got different doses for radiation compared to what you would do nowadays. Because nowadays, I think if you are in the normal radiation regime, you would not expect a large amount of contrast enhancement. I mean, we've seen quite a few of asymptomatic patients just to check what it looks like. But maybe if it's maybe it's years and years, it might be more difficult because of an increase in radiation damage. But yeah, I rather tend to call most things, if in doubt, it's rather negative way. So yeah, I also completely agree with the clinical presentation. If there is additional or new pain, in most cases, it's just a recurrency, unfortunately.
But with the clinical terms, I must admit, I don't completely, but I disagree. Because the problem that we have is that the patients both present with pain and tremendous pain and functional loss. So the symptoms are very similar in our experience, in my clinical experience at least. So, I mean, of course, I don't have I don't see the numbers of breast cancer patients that you see as radiologists for sure. So I see the patients that come with the question, okay, is any surgery being, can any surgery be done or carried out that could help the patients? But the common symptom is pain. And I don't see a big difference in the kind of pain. I see a difference, and then sometimes we operate, sometimes we don't, depends on the general health status of a patient. But so pain is, at least to my experience as a nerve surgeon, is not the main distinction between going for recurrent malignancy or having a post irradiation. Maybe I think, and this is something that would be to all of you one of my questions, as to look out for the future. We will have talks on that. But something that is very difficult to assess is the nerve vasculature. So my interest would be to see how nerve vessels are. There will be strokes in nerve as they are in any other neural tissue. So we don't know we don't know a lot about this. So this is something that, as a next step of imaging and additioning, and maybe and I have a lot better understanding, would be the thing that I would, wish for. So let me check. No, there's no more question from the audience. So since time moves on, we will move on with the next talk. And I'm very happy that Maggie McCann joined in. I saw her talk in Chicago this year in EANS, and I was very much impressed because it's the first time that I saw an excellent talk on imaging, but on the same showing me, or showing not me, but showing to all of us what actually happens within the nerve if a nerve in MRI, especially DTT, DTI, appears in a certain way. So I'm very happy to have you here, Maggie, and I will hand over the screen and the audience to you. Thank you very much for being with us.
Well, thank you so much for having me. It's really an honor for me to be on this panel. I'm very much on the preclinical side at this point in my career, so I'm learning a lot today, which is fantastic. Let's see here if I can get this up and running. Okay, so as mentioned, I am Maggie McCann, and today I'm speaking about diffusion MRI biomarker validation through 3D histology. This is work I've been doing at Barrow Neurological Institute in part for my PhD. So, I have no disclosures. So peripheral nerve injury diagnostics are nonspecific and not predictive, and this creates a problem because it can lead to a delay in diagnosis and an uncertain prognosis, which, as we know, is frustrating for both patients and clinicians. A possible solution to this diagnostic dilemma that we've been looking at in our lab is diffusion tensor imaging, or DTI. So it's a kind of MRI that uses the apparent diffusivity of water to probe underlying tissue architecture, and it's direction dependent, and axons are what we call anisotropic. So the quantity on which I want to focus today is called the fractional anisotropy. I apologize if this is a little bit basic for everyone, but essentially it's a value that runs from 0 to 1, with 0 being something like a cup of water. So you can imagine if you drop some dye in the water, it can diffuse in any direction. So that would be close to 0, whereas if you have water in a celery stalk, it will run up and down the celery stalk, and that would be a value closer to 1. So looking at nerves, a healthy nerve is going to be closer to the celery stalk, closer to the one end of that spectrum, whereas an injured nerve, which has lost myelin and axons, will be closer to the 0 end of that spectrum, closer to the water cup. So the advantages of using DTI to track peripheral nerve injury are that it's non-invasive, it's more specific than conventional MRI, and it's quantitative, as I mentioned. However, it requires validation because you're measuring on a millimeter level scale tissue architecture that exists on the micron level. And these are just some beautiful images from Monica Hall showing the different causes, the different things that can cause a drop in FA. So for example, you can have 2 healthy crossing fibers in the middle of your voxel, and that might look like the FA's dropped. That's less of a concern usually in peripheral nerve, but something to look out for, for the cranial nerves and that kind of thing. For disorganized, you can have disorganized growth, you can have swelling, edema, and fragmentation. All of these can affect your MRI parameters. Currently, histologic validation is kind of the gold standard, but this creates a mismatch between the 2D light microscopy and the 3D weighted MRI image. So what we wanted to do was validate 3D MRI using 3D histology. And the approach we took was we had 3 groups of animals. We had a control, a crush, and a cut repair group in rat Sprague-Dawley sciatic nerve. And we used the sciatic nerve because it gave us an image large enough for our MRI to actually detect, because these guys are so small. We decided to look at 2, 4, and 12 weeks as our time points. 2 weeks, we expected to see still a lot of inflammation. By 4 weeks from previously published data, we knew that the nerve should be regrowing across the site of injury, and we expect all of our crush animals to have recovered by 4 weeks. And then 12 weeks is more or less considered a chronic time point in rats. At these 3 time points, we were looking at 3 different things. We had an ex vivo DTI. We had this 3D pathology method that I'll talk more about in a minute that we developed. And then we were running baseline behavior and collecting behavior weekly. And so I'm just going to walk through each of these, and I will combine both the methods and the results to keep things simple. So the behavior that we ran 2 different assays, and these are well-validated behavioral assays in the rat. One is called the sciatic function index, and the other is called the foot fault. So the sciatic function index, or the SFI, is just an empirically derived formula that quantifies nerve function from foot placement. And so as you can see with this cartoon that I have here, literally what you do is you take a rat, you paint its paws with paint, it runs up a little ramp, and then you can measure the paw prints it's left behind, plug it into this equation, and follow. It'll spit out a number that then you can track over time to quantify nerve function. The foot fault is similar. You place an animal on a wire grid, you count how many times its paws fall through the wire grid, and that gives you a weighted average of the surgical versus the hind limb number of faults, or times the paws fallen through the grid. And so the results that we saw from this, and the nice thing about this was that we were tracking the behavior weekly, so we were able to get these results very early on and see that things were progressing as we expected. So we saw no real change in our sham animals. Our crush recovered by 4 weeks, actually many of them by 3 weeks, if you look at these light blue lines. And then our cut repair had poor and variable recovery. So this was, as I say, kind of par for the course, matched what we've published in the past and what we're expecting to see. So next, I want to turn our attention to the MRI scans that we ran. So in general, the tissue processing we were doing, this is a preliminary study. So we did ex vivo DTI. So we'd remove the sciatic nerve from the rat, we'd fix it, then we'd run it in the MRI, and then we'd do our histology, our clearing and immunofluorescence that I'll speak more about in a minute. And then we image on a confocal microscope. And so our DTI protocol for these preclinical studies were basically we just wash the tissue, we use gadolinium to enhance the contrast, we mount it in an inert compound called formalin, and then we'd run the scans on our 7 Tesla preclinical imager at 2 different B shells, and we were able to achieve the resolution listed there at the bottom of the slide using this protocol. And so the results that we got from our preclinical DTIs were once again kind of what we had predicted and what we had expected to see. So these are just example FA maps from these ex vivo DTI scans that we ran. And you can see this is a cut repair nerve. And you can see that this would be the site of the repair. So that corresponds to the 0 on the graph. So the 0 on the graph is more or less where the lesion site occurs. And you can see proximal and distal to the site of injury, the FA. This is an average of the FA for each cohort. You can see that the FA is quite a bit higher, and it drops to almost 0 at the site of injury in the cut repair animal. Whereas if you look over at the crush, you can see that there's quite a bit of variability, but you don't have that same drop in FA near the site of lesion. And this is unsurprising given how much less disruptive the crush injury is to tissue compared to the cut repair injury. So far, so good. So then we wanted to turn our attention to the 3D histology, which is kind of the meat of the project and what we spent the most time on. So for the sake of acquiring the pathology in 3D, we combined tissue clearing with immunofluorescence. And so tissue clearing is a rapidly advancing method that basically the way it works is you remove the lipids and the pigments from a tissue. This increases the transparency and decreases light absorption and scatter as the light goes through the tissue. And then the final step is you use what's called an index matching solution. And essentially what that does is it suffuses the tissue with what I kind of think of as an even lattice work, so that when the light hits the tissue, the side scatter cancels out, but the forward propagation of light is allowed to continue deeper into the tissue. And so this, as I said, allows the light to penetrate deeper into samples. So when you combine that with, your average run-of-the-mill immunofluorescent labels, you can see your markers much deeper in tissue. This is just a depiction for anyone who hasn't been in a wet lab recently of how immunofluorescence works. You have a primary that targets your antibody or your protein or your your protein of interest, and then you use a secondary antibody to target that primary antibody that's conjugated to a fluorophore, and so you can light up individual protein markers. And so we targeted neurofilament and myelin basic proteins, since those are ubiquitous and found in in peripheral nerve. So this was the overview of the tissue processing protocol that we ultimately landed on after many iterations. Essentially what we did is we removed the sciatic nerve from the animal at the time of euthanasia. We fixed the tissue. We ran the MRI scan I mentioned earlier. This is a further fixation step. And then we did end up cutting at 120 microns. So initially we were running these scans in whole mount nerves, but we had a lot of trouble with the antibody penetration. And so we found 120 microns to be thick enough to give us some beautiful 3D information while also allowing the antibodies to penetrate. So following the sectioning, we would stain with the immunofluorescence. We do the index matching step I mentioned earlier, and then we get our images from the confocal microscope. And this is just kind of a fun overview that our neuropub department made for me, showing where the sciatic nerve runs in the rat. This is where we take our sample from, and then we cut it into 120 micron sections. We take a section from the center of the nerve, and then that is what you see here. This is a slice from the center of the nerve at 120 micron thick section. And then within that, we can further zero in and take 40x very high resolution scans at the full depth of the samples that we were acquiring. So using this method, what we did is we took 40x sections proximal within and distal to the site of lesion from these center cuts from the nerve in all of our cohorts. And this is just a representative crush and a cut repair. And we can do multiple different things with this data, and we're still working on different things that we want to do with it. But this is an example. You can see on the top, this is the 10x projection, and those white boxes are projected down below. And so you can see how the tissue looks reorganized following an injury proximal within and distal to the site of lesion. And we can kind of make a global comparison. On the top of the slide there is the 10x pathology projection. In the middle is the diffusion MRI from the same nerve. And then at the bottom is the fractional anisotropy map we derived from this diffusion weighted MRI. And you can see that within the site of lesion, where you grossly see a neuroma formed, the FA drops quite low, whereas proximal and distal to it, the FA appears to come back up and is closer to the 0.8 end of the spectrum. And then this is just showing a recovered crush animal on the left compared to a neuroma formed in one of the cut repair animals. And so you can kind of scroll through the tissue and track these axons visually and see how the tissue looks following these injuries. These are representative samples of those 40x stacks that we acquired from within the lesion centers for all of the different cohorts. And as you can see, as we predicted, by 4 weeks in the crush animals, the nerves are regrowing across the site of lesion. This animal clearly formed quite a large neuroma. And then by 12 weeks, this is another cut repair animal that is recovering. And the crush has more or less recovered, or has recovered by 12 weeks. So this was all like really beautiful imaging, but we wanted to find a way to quantify it. And so what we ended up doing was deriving structure tensors from these 40x stacks. So whereas MRI relies on water diffusivity, we were able to use a similar idea and derive tensors based on the change in intensity that we were seeing within these pathology slides. And so these are those individual axon tracings, directionally encoded axons here. But if you zoom out a little bit, if you take a larger neighborhood and kind of average those tensors over a larger area, you can derive an FA map for the entire 40x section. And so that's what we did here. And so on the top, you can see these are the pathology slides, proximal within and distal to the site of lesion, and the structure tensors down on the bottom. And where you grossly see a change, a drop in coherence in the pathology slide, you can see that on the measured FA map that we derived, there is also a drop that corresponds to that. And we see that both in the neurofilament here, and then also in the myelin basic protein stain that we ran. So we took these values that we had derived and we compared the FA that we derived from our histology structure tensors to the FA that we derived from our MRI, our DTI scans. And what we found was, particularly within the cut repair cohort, we found a very strong correlation between the histology-derived FA and the DTI-derived FA. And so this led us to the conclusion that what we're seeing is that the FA correlates between the two, from the MRI to the histology. And so it's very exciting. We're still, as I say, we're still figuring out all the different ways in which we want to use in which we want to analyze this data, but this is a very exciting start for us. So there are some limitations to this study. First of all, the structure tensor and the diffusion tensor measure different things physically. And so you just want to be careful when you make comparisons to keep that in mind. The other thing we encountered is, as I mentioned, we were initially starting with whole mount, but we ended up slicing the tissue at 120 microns. And so that gives us a limited Z coverage and also means that, I'm having to manipulate the sample quite a bit during this processing. So that confounds the direct registration to the MRI. And we've found creative ways around that, but we'll talk about it in just a second with the future directions. But that is one other setback here. But overall, it's a preliminary proof of concept study. We need more time points and numbers, but we're very excited about these preliminary results, and we're excited to see where it goes next. Some of the future directions that we're currently working on, we're establishing a transgenic colony. So we have rats that express endogenous fluorescence, and we're hoping that using these animals, we are going to be able to get the whole mount and get the rest of that Z coverage so that we can see the entire nerve. The other exciting project that I've been working on is using other validation methods. So we're looking at potentially using micro CT, which would not only give us, not only let us see the entire nerve, but would also give us information about the surrounding tissue structure. And since we could do in situ micro CT imaging, we could directly compare that to the MRI. We are also actively recruiting patients for clinical trials here at Barrow. And then this is a method that can be used for the validation of other advanced diffusion imaging methods. So we're really just getting started with it. So with that, I really just want to thank everyone involved in this project. I had a lot of support. In particular, I want to thank my mentor, Dr. Richard Dortch, everyone here at the Barrow Neurological Institute, and our Innovation Center, and the Vivarium staff, and then my home program of the Creighton MD PhD program. And with that, I just want to thank all of you for your time, for the opportunity to be here. That's my contact information, Dr. Dortch's contact information. And I guess we'll move into discussion with that.
Dear Maggie, thank you very much. Fantastic. Highly interesting. And what you promised to add something new after Chicago, and that was quite some. So congratulations for your work. And well, it's open for discussions, and I'm very curious to hear our experts. What's your impressions about this? So please go ahead.
I have a few questions for Maggie. Thank you very much for your presentation. For the clinical trial, which kind of MRI machine will you use?
So right now, the method we're recruiting for right now is the DTI. We are in the middle of a scanner change. So I believe I'm not sure which one we're finally landing on and when we're going to be getting it. And then that is another thing that we're working on, or that the lab in general is working on. So I'm very much on the preclinical side, but something that I know that we're working on the clinical side is figuring out a way to kind of get a standardized protocol across different MRIs at different institutions.
Okay. As Daniel said, DTI, DTT sequence has been here for quite some time. And at the beginning, I had a tremendous problem with the timing, because these sequences took so long to be acquired. Sometimes I was with the patient for 20 minutes to find out later on that it was useless because the patient moved, for example. So from that moment until now, I got to reduce the timing up to 5 minutes, and it's quite okay, but I still have problems if the patient had a trauma and had some metal artifacts. So one thing that I'm really eager to see is how in the lab this will be solved.
We are eager to see the same thing. So we actually have one of our postdocs is working on a project right now looking at spinal cord like hardware implants and how to deal with that. That is once again not an area that I have spent that much time in, but I do know that is an issue. It wasn't an issue for my project. I will say the DTI images that I'm running, my nerves, I mean, we were using a 7 Tesla. Even so, my nerves are very small. And so the scans I'm running ex vivo actually take 22 to 24 hours. Now, obviously, you cannot do that in a clinical patient. And, this is as I say, ex vivo. You couldn't do it necessarily even in a rat. I believe some of the images I've seen take 10 to 15 minutes for some of our nerve imaging. And I know that, we are constantly working on trying to find ways to reduce the timing on that. And, I think people, as you mentioned, are kind of looking at potentially trying to use AI to help with some of that. But I couldn't necessarily speak to where that stands.
Daniel, what's your opinion? Since the Heidelberg group has quite a setup of scanners, so what's your impression?
Yeah, thanks a lot for this great talk. I mean, it's a very pertinent and very important question to really correlate what we are actually looking at, because I mean, as we are all aware, I mean, diffusion tensor imaging is not really looking at nerve fascicles, but merely some kind of simplification what we are actually looking at. And so I think this has been an open issue for quite some time, and I really appreciate all the efforts to go for tissue clearing, so that I guess you will try to get a one-to-one correlation of this ultimately, or what is the future direction there? Because I mean, of course, it would still be better to have a whole mount nerve image at that point.
Yeah, and that is something that we have been looking at. And I mean, to be honest, there's so much supportive tissue in the peripheral nerve. I mean, it's incredible. So I worked in spinal cord before, and I wasn't doing tissue clearing, but I was doing immunofluorescent work in spinal cord. And it was kind of stunning to me to see how much supportive tissue there is in peripheral nerve, even compared to spinal cord, and how hard it is to get the antibodies to penetrate. So we looked at neurofilament and myelin basic protein, which are, obviously axonal markers. But I do suspect that it won't be a direct, like, even if we get a one-to-one correspondence, my guess is that there is also some supportive tissue playing a part in all of this, if you're talking about the water diffusivity. And that's actually why I think the micro CT study could be very interesting as well, because there you'd also get, I think, more of the supportive tissue included, as opposed to the immunofluorescence, where you have to pick the markers that you're going to see. You can only really get 2 or 3 really good immunofluorescent markers. After that, you're kind of you got some overlap in the channels.
And there is one more question I would be highly interested in, just concerning these animal studies with the cut repair animals. I mean, you were showing nicely an animal where you had this neuroma formation. Were all of them also doing very were they all doing a very, very bad job afterwards on the functional level? Or because I just know that for all of these animal studies, yeah, unfortunately, most of them recover anyways, even if the nerve doesn't look very good.
So actually, no, they were not all. If you look at the behavior slide I actually had about, like, in the 12-week study, 2 of them looked better, 2 of them weren't doing as well on the functional side. The issue for me that I always run into when I'm doing any kind of rat behavioral assay is it's incredible how well animals can get around the tasks you give them and how well they adapt. So even there, some of the successful trials, if you're counting how many times does the paw fall through, some of the animals learned, okay, my foot isn't functioning that well, so I'm going to use down here. So all that is to say, behavioral assays aren't perfect, but no, all my animals were not recovered well. Some of them you could.
So there was a very, very close correlation on a functional level to, at least to these neuromatous changes of the nerve when the nerve was not recovering very well.
Yeah, I'd say it was a fairly good correlation. Yeah, not perfect, but good.
I have another question. Talking about this microstructure and all this tissue that we're learning about, did you have in mind to move forward with the radial diffusivity, for example? Or
yeah, so we would like to look at more parameters, and like the radial and the axonal, or the axial, the AD and the RD. The thing is, so because we did end up having to cut the tissue, And this is, we had I mean, it's a small study so far. So I think to really tease out all those differences, we will need more animals. We'll need a bigger cohort. And then there are also like we're still working on post-processing corrections just insofar as to kind of make sure that we have the same resolution between the MRI and the pathology. And so there are things that we are working on there to get that correlation better, or to get that comparison better, so that the comparisons we're drawing are better, if that makes sense. But I think, go ahead.
Please, no, please.
No, I was just gonna say, I think those are things we're interested in looking at. But when we kind of considered looking at them at the moment, we're not there yet. And I don't know if we'll be there with the current data I have, but hopefully in the future that is something we can consider.
So I want to have just two comments. So one is, since I'm an ultrasound lover, we've done some work on correlating exactly what you showed, that over time the nerve somehow reorganizes and becomes more and more physiological appearance of a nerve again. So this is what we saw very roughly, I must admit, with the 15 megahertz probe on big nerves too. So of course, I would be highly interested to have the correlation of MR and ultrasound, since it's better available. And of course, on the long run, to have an idea, to have something like an in vivo monitoring of nerve regeneration. And we leave out the nerve muscular junction. And the second is, in a lot of radiological reports, we read about the T2 hyperintensity. And actually, nobody knows what it is, because they are nerves that work fantastic. They have no problems, no pain, no loss, no nothing. And the nerve looks quite horrible. And there's a T2 hyperintensity. Then we have other nerves that don't look too bad, but they're T2 hyperintense, and they don't work at all. The patients suffer, they're in pain and everything. So do you think that the methods that you implemented could also be suitable to address this question, to solve somehow the riddle of this T2 hyperintensity?
I mean, you could definitely look at that. I guess the question would be, yeah, that's a tough one, in the sense that I'm not sure if it would answer or not. Like, I'm not sure what the underlying, you could try to look at it. I think the problem there might be, is it going to come down to a difference in really what we're measuring is density and coherence of the fibers. And so if the T2 hyperintensity is based on something else, if it's based more on the fact that there are these other supportive tissues and all the other things that affect water diffusivity, which is far more than just the axons and the myelin, then you'd have to be very selective in which immunofluorescent markers you chose, I think, to really tease that out. But I mean, you could certainly give it a shot, but I don't know that the markers I'm using would work that out, if that makes sense.
I just want to say in response to that too, is that your parameters are incredibly important, right? How you set your TR and TE, if you're using some kind of inversion pulse. I mean, it's really, really, really makes a big difference in terms of looking at T2 hyperintensity. The MR parameters are really critical. And if you have very long TR and very long TE, everything looks great. And that's sort of a problem with stir imaging too. And so I think, what was shown here was really beautiful and really interesting, but on a clinical standpoint, it's really important. Like, we cannot use the same parameters that neuroradiologists use in the brain. We can't use the same kind of parameters that abdominal imagers use. It really is quite specific, and I think that makes a big difference. So I'm sorry, I'll be quiet now.
Yeah, sorry.
Daniel, please go ahead.
I also just wanted to briefly comment on this T2 hyperintensity stuff, because of course that is one of the big problems. We know we are extremely sensitive, but unfortunately not very specific with the underlying pathology. And I'm really of the opinion that if we get good diffusion tensor imaging, this will probably help us to distinguish the underlying architecture of the nerve, because we have so many different ways why a nerve can look bright.
Yeah.
That is just, it's just not enough.
One.
Go then.
Yeah. Well, we certainly know that there are some nerves that are spontaneously a bit more hyperintense, like the ulnar nerve at the elbow. I also see that in the medial nerve at the wrist. And that is secondary to the amount of myelin and endoneural fluid. This is normal. So when do I interpret that I am seeing a pathology? When the fascicular pattern is affected. And then if I inject contrast media, there is uptake. So we have all these tools. We do not only see hyperintensity, we try to go farther. And that's why we really need very good high quality images to be able to see the fascicular pattern and everything that is in the nerve and surrounding the nerve.
Well, I agree that you do, the group that is here, but I think you would also agree that not everybody does this in this meticulous way. So we have a lot of reports from people who do not frequently do nerve imaging, talking about T2 hyperintensity, and what happens that all the patients go crazy because they think they have something or they don't think that they have anything. So this is, well, we will not solve this problem today, this is for sure. But I think also we have the same issue with our educational system in terms of peripheral nerve surgery, as the neurologists have with electrophysiology, and I guess as you in your community have with nerve imaging. I mean, the groups, I can only talk of Germany, the groups that really do nerve imaging are basically, well, now they spread, but the crest is the same, so to speak. They all come from the same place or from over the ocean. So, this is this will be, something to work on. Okay, so last but definitely not least, it's a huge pleasure for me to go over to the next talk and thank Maggie once again for this beautiful talk. I will hand over to Daniel Schwarz from Heidelberg, so one of basically the nerve imaging center in Germany. Of course, with Quakenbrück now, but we have the pupils of Heidelberg. They spread all over Germany, and we are very happy to have you here with us and tell us about the imaging of the dorsal root ganglion. And we are very curious to hear you. So please, Daniel, go ahead.
Yeah, Christian, thanks a lot for having me. It's a huge honor to present here the work which is currently available on the visualization of pain or of the peripheral pain. Of course, this is also a very painful topic because it's not so easy, and it's also more of an outlook, I would say, because this specific topic has not yet entered clinical routine very widely, but I will try to provide some information why the dorsal root ganglion in the future might be a real interesting target also for a therapeutic decision making. Sorry, I need to get this. Yeah, I have no relevant financial disclosures connected to this talk. So what is to come? At first, I want to talk briefly about the rationale and the basis of dorsal root ganglion imaging in general and why this might be an interesting goal for imaging. I will talk about imaging techniques that are available and also about the different parameters which might be interesting to look at and where we might find some pathology in relation to certain disease conditions. And I will conclude with challenges and caveats and provide a small summary and outlook towards the end. So turning now to the rationale and basis for dorsal root ganglion imaging is, of course, the dorsal root ganglion itself. So this is a representation which is not from a human dorsal root ganglion, but actually it is a composition of what we are facing. And why it is interesting, of course, we all know that it is probably the most prominent center of peripheral sensory sensation and also of pain. What is interesting here is the overall architecture, because the DRG is composed of sensory neurons and supportive satellite cells, which are typically located in a cell body rich area of the DRG. And in contrast, we also have a dense parenchyma of nerve fibers and fine connective tissue stroma, which is typically interspersed or more located towards the center. And of course, we also have an important vasculature with large fenestrations, which make this structure a very likely target for hazardous substances or pathologic conditions in general. If we would like to, if we want to have a look at the architecture in general, we need to keep in mind that the sensory neurons and supportive cells are typically based in the periphery. The dense parenchyma is rather located in the central part of the dorsal root ganglion, and the vasculature with the large fenestrations again is connected to the periphery. And this is what we need to have in mind. Now here the vasculature as an overlay, where you can see that actually the cell body rich area, so where the sensory neurons are, is really prone to all these influences which might arrive at the dorsal root ganglion via the blood. And this is what makes the structure so incredibly interesting in terms of diagnostic imaging in general, because we might find specific pathomorphological changes which are connected to this architecture that may give us some hint in terms of pain sensation. So the important question, of course, in the end is, can we see the pain? As we all know, this is an imminent question, and it's very hard to answer in many circumstances. But I will show you that although the dorsal root ganglion is a very small structure, it actually provides some interesting insights. So what do we have from a technical perspective? What we can image via MRI? On the one hand, of course, the most basic one would be the volume. We can also have a look at the T2 weighted signal intensity, a bit similar as this has already been shown for the peripheral nerve. It is a very sensitive marker, which may give us some insight. And towards the end, I also briefly want to comment on functional parameters that might also be linked to the vasculature. Just briefly talking about the prerequisites of imaging in general, this has already been touched by the other speakers. As you know, for peripheral nerve imaging and for the DRG imaging in particular, it is very important to have a high spatial resolution for optimal morphological representation. And especially the dorsal root ganglion is also a structure which might be quite irregular, especially since it is linked to different segments of the vertebral column, and at each level they might look a little different. So if we want to have a very specific look at this structure, we need a 3D T2-weighted sequence with an isotropic resolution of less than 1 millimeter. And of course, we also need a solid PET suppression And we should also try to optimize the signal yield so that we can have a very good signal-to-noise ratio, meaning that we only want to do this examination on high-field MRI, maybe increase the number of averages, or use other tricks to do so. Maybe the most striking finding of the last couple of years, I would say, was the finding that neurofibromatosis type 2 actually has a very, very large implication for the dorsal root ganglion. In this work from 2018, it was found for the first time that the gross volume of the dorsal root ganglia can actually be used very, very well. On the one hand, to diagnose neurofibromatosis type 2, and also to use it as a marker to distinguish this pathology maybe from schwannomatosis, which is sometimes a bit difficult if you don't have the genetic test ready at the time. So the DRG volume can reliably distinguish between the two. And what was also found in a later follow-up study was that this is not only the case for adult patients, but you can even use the volume in children early on in their lives to diagnose NF2, even though those patients or those children don't feel any pain or don't feel any neuropathy at that time. So this is a very consistent finding, which is actually very similar from the diagnostic performance to the bilateral vestibular schwannoma. So this, to some extent, may serve as the kickoff point, because it shows how interesting this structure actually is and how different even the gross volume can be. That was why we also used the volume to look at different other neuropathies which are known to be linked to neuropathy and pain, especially chemotoxic effects. And pain is, of course, one of the most important reasons why chemotherapy is often suspended during therapy. So we took the oxaliplatin substance as an example of such chemotoxic agents, and actually looked how this oxal-PNP was linked to the volume of the DRG. And what we found was that although the peripheral nerve actually looked pretty unremarkable and didn't show typical T2 hyperintensities, we found that we had a very consistent increase in the DRG volume of the L4, L5, and S1 dorsal root ganglia among the patients suffering from oxaliplatin-induced peripheral neuropathy. But of course, there are also other polyneuropathies which are linked to painful phenotypes. One of the most maybe eminent other genetic disease is the Fabry disease, which has also been studied more or less extensively with regard to the dorsal root ganglia. And in this initial work, it was also found that on the quantitative level, you get a large volume increase throughout all pairs of dorsal root ganglia in compared to normal volunteers, as is shown here in the bar chart. This is quite interesting. Of course, it follows the rationale from what we know from the histology, but it was the first time that this can actually be evidenced in the human in vivo situation. And it represents the deposition of the sugar molecules within the stroma. In another, more recent paper, it was also shown that a very similar finding of an increase in dorsal root ganglion volume was also true for people suffering from spinal cord injury with painful neuropathy, but I'm not going to show you that paper specifically because I want to go for another neuropathy, which is also very common. In fact, it's the most common one, which is the diabetic polyneuropathy. And in diabetic polyneuropathy, it was also found that there was something going on about the volume of DRG, but it was not an increase with increasing clinical symptoms, but in fact, there was an atrophy of the dorsal root ganglia. As you can see here in the data, that in more severe DPN, the DRG volumes are actually reduced. So what we can conclude from all these studies is that in many cases we have an increase of the DRG associated with painful phenotypes, but not in every case. Yeah. So this is definitely something what needs to be extended to other disease as well, but that is what we know for now. And now going to the T2 signal intensity, which may not be as accurate as volumetry, because it depends on so many different parameters. This is again from the same paper on diabetic polyneuropathy, and here the opposite is actually true. So here we see that with increasing symptom severity of the neuropathy, we see an increase of the signal intensity of the DRG. So this is very similar to what we already know from peripheral nerves in general. There is not so much work on the T2 signal intensity of dorsal root ganglia. Just a very recent one where this was extended to the Fabry disease again, and this was also shown to behave in the same way. If you now have a look at the dorsal root ganglion here on the MR images and the manual segmentation of the DRG, you see that in the healthy control and in the symptom negative Fabry disease, you already see on the one hand an increase in volume, but also an increase of the signal. The most severe signal increase is here in the neuropathic phenotype of Fabry disease. This is a finding which was presented only very recently. But again, a bit similar to what we know from peripheral nerves, T2 signal increase seems to indicate pathology in general. I was already hinting at functional imaging. Of course, this would be very interesting if it worked, especially with regard to the vasculature and with regard to the large fenestrations, which are of course quite different from the peripheral nerve, where we have a very dense nerve, blood nerve barrier. And this is actually possible. This is a technique which has been proposed in a couple of papers already. Just to show you the concept here, this is the first paper where the perfusion imaging was done in healthy controls. And there you can see that the anatomical architecture, which I was talking about earlier, you see that in the periphery of the dorsal root ganglion, again, you actually get the increased perfusion in contrast to the core, where you have the more dense fibers, and where you have again the blood nerve barrier. If you compare these compartments on a quantitative level, you already see that the dorsal root ganglia in general have an hugely increased permeability compared to the spinal nerve just adjacent to the neuroforamen. This can actually be used also to probe pathology in the dorsal root ganglion again, showing at Fabry disease, where you have this specific setting of the sugar depositions, which is of course very specific to this disease, but just as a proof of concept, you can see that here you have a huge decrease in the permeability, on the natural permeability of the dorsal root ganglia. As you can see here in the K-trans values, which are consistently lowered compared to healthy controls. On the other hand, if you again have a look at the controls of the sciatic nerve, you see the spinal nerve actually doesn't show any difference. So this might also be a very interesting target for imaging pain in the future. So the capillary permeability is largely reduced. So taken together, looks quite interesting for future imaging, but of course we have a couple of challenges and caveats which we need to bear in mind. One very important thing is that the translation to the single patient level has not yet been fully accomplished. Most of this data is group data. And if you have a look at for instance, for the physiology of the volume of the DRG, you see that you have inter-individually, you have a large variability of the volume. So you cannot just come up with with an absolute number as a cutoff value. So you need to somehow normalize the volume to something to know what is actually going on. And you also can see that the volume depends largely on the segmental level in general. The other thing is that a correct DRG volume estimation and other post-processing can be quite tedious in general and take quite some time, which may not be easily available in the clinical setting, but maybe AI might help in the future in that regard. Another important caveat is that it has only been established for the lumbar spine level, which is because we have the largest DRG at these levels, and other levels might be even more challenging to image in general. And also only established in a few disease entities by now. But as I've already been telling you, the DRG in general represent a new exciting target in peripheral nerve imaging. There are very interesting associations of pathological findings to different disease conditions. And most concepts, however, still need to be translated to the individual patient level. So more work is definitely necessary to finally answer the question, can we see the pain in clinical routine? So for now, we need to answer, okay, indeed, there is growing evidence that we may see the pain indeed, but we need to have a look at the right findings and concepts in different disease entities. So thanks a lot, and I hope this has been an interesting outlook for you.
Thank you very much, dear Daniel. Fantastic talk. And well, it's always good to think that what tends to happen is that peripheral nerve lesions are limited to the periphery, which is, I think, completely wrong. And especially in the traumatic nerve lesions, there are excellent studies that, well, damaging your nerve damages your brain or changes your brain, changes your muscle, changes your spinal cord, changes your nerve, of course. So I think the topic of pain in clinical terms for the most of the patients is the worst. So at least in the traumatic pain patients, if they can decide to have the limb functioning or no pain, a lot of them will choose no pain. And I think the dorsal root ganglion is one of the essential keys to go for it. So I'm very happy that you and your group take a deep look into that. And I was very impressed by one of the first slides where you showed the fantastic vasculature of the dorsal root ganglion. So how did you do this in technical terms?
You mean from the histology?
Yeah.
Oh, that was actually borrowed from a paper.
Okay, because this is possible with MR or
no, that was no, with MR.
Not yet, maybe. Because you have the high resolution.
Maybe we should combine efforts and try to get the DRG as a whole mount specimen, and then maybe do some images with Maggie together.
Well, there's actually one of the really neat things about the micro CT project is there's a really cool new dye that you can perfuse an animal with the dye, MRI image it, and then you can change the temperature and the dye hardens, and so then you can see where the blood vessels are going. So
yeah,
there are possibilities there.
Yeah, that would be great. Yeah.
So well, I mean, since I don't treat Fabry and all this, I treat in pain. In terms of pain, it's mostly, well, one is compression. So one is, of course, traumatic and tumor. So as you showed, well, this basically was Tim's work, if I remember
Yes.
well.
Yeah.
So to show that in NF2, I was surprised actually, because one of the typical clinical features of schwannoma patients is that their schwannomas are a lot more painful than in the, let's say, non-schwannoma population. On the other hand, the NF2 patients suffer a lot from polyneuropathy. How is this with NF1? First question, did you go for that? And the second is, did you go for compression? For example, in carpal tunnel, or now let's say carpal tunnel, but because you say it's more for the lumbar, so we need to find lumbar or lower limb entrapment.
Yeah.
Or do you have any experience on traumatic nerve lesions in this regard?
Yeah, to be honest, we haven't done it in clinical practice because on the single patient level, we just don't know what to expect actually. Okay. And scientific projects have been started, I would say.
Okay.
So, but there we don't have the results yet ready.
Fine. I'm very curious. Dani, Maggie, you want? So Kimberly, Professor Amrami needed to leave. So, well, we will thank her nonetheless once more to have her here. And Dani and Maggie, you want to comment or question and discuss on Daniel's excellent talk?
Yeah, I think the neurosurgeons should know that it's very difficult to evaluate the dorsal ganglion root because it's part of the peripheral nerve system, but at the same time has these characteristics that take this very specialized tissue. It's the only place in the peripheral nerve system that uptakes contrast media. So it is difficult to say if it is pathological or not. And what we do when the patient has bilateral symptoms, so we cannot compare the volume from one side to the other because we don't really know the volume of this structure in male, female, normal persons, and we don't know if it changed over time. There are a lot of questions that are still there to be responded. And it's a shame that Kim is not there. She has a lot of experience with diabetic patients and diabetic neuropathies. It's very interesting. I'm really looking forward to see how this jumps into individual persons.
Yeah, I think my comments, I mean, as previously noted, I'm not really on the clinical side, but I know something we're always discussing when it comes to these clinical scans. I mean, your images are so beautiful, but I know that sometimes we have trouble like with patient positioning and the length of scans and that kind of thing, and that's always a problem for us when we're looking at, you know, these new sequences that sometimes the lab is looking at. And I look at the images you have, I'm like, that's fantastic, and I wonder how long though, and how easy it will be to make those become kind of standard of care. And then what trouble you run into with patient positioning, because, you know, if you're imaging these pathologies, you know, is it pain limited? Like if you have to put them in like the Superman pose or something, you know, are you going to be able to do that with every patient? Or are are these studies going to be somewhat more limited? And I think that's something we want to talk to with our own studies. So.
Yeah, unfortunately, these are the challenges in everyday practice. I mean, yeah, we have these patients and they are not rare, where it is unfortunately a bit more difficult. And of course, the more you go into quantitative imaging, the more difficult it will be in individual patients that might not be so well suited for the Superman position, for instance. So that is why, for clinical purposes, it would be very good if maybe by means of the quantitative measures, you come up with the easier readout parameter to target the problem. But yeah, you need to scan many people so that you can actually come to that point.
Definitely. Okay, so there's no questions from the audience. I guess they are even more blown away after these 4 fantastic talks. I really enjoyed this webinar, and it made me, well, wonder a lot, think a lot, be impressed a lot. So thank you all very much for joining us. And this, of course, goes to Professor Nami as well. And I hope we will have you with us in the future. And we will be very, very curious to be updated on your fantastic projects and work. So feel free to, well, with most of you, we are in contact all the time, but feel free to, be with us all the time. And we will definitely not forget about you and get on your nerves once in a while to know how things are. So this webinar was recorded, so whoever missed out on it or wants to go through it again, it will be available via the homepage of the EANS. So feel free to go for it. And I think it's worthwhile a lot to go through any of the presentations today in detail to, to even develop a deeper understanding. So once again, thank you very much. Thank you, Anna Rek from EANS. She's the spirit of all this. She makes all this possible in the best, easiest, and smoothest ways possible. So I cannot thank her enough. And see you soon. And the next webinar will be announced, in fall. So let's see, but you will know soon. Thank you very much again for your time and your dedication. Thank you.
Thank you very much for the invitation.
Thanks a lot.
Bye.